webinar is now live.
Yes, because Manju connected to the webinar, I believe.
There's an internet outage. There's internet problems in the whole neighborhood.
Oh, I was just told there's an internet problem in my whole neighborhood. We just got an alert. So Manju gets in. Manju?
Manju is not
She
here.
should be ready to-
yet. She is not here yet.
Okay. Okay, Suchi, let me tell you. Okay, at 6:15, you're opening? Or when do you open it for people to come in? Can you hear me, Suchi? Can you hear me, Suchi? Hello? Can you hear me? Oh, Yashuan, you're a new host now. I see.
Yes.
That's
She joined.
okay. I was frozen a
Yes,
couple of seconds ago.
I was also kicked out. Is it because of rain today?
Okay, I
Let
don't
me-
know. It is our internet connection. So probably we need to alert our audience, and please be patient when there is some technical glitches that is unanticipated and obviously disturbing, but it's beyond our control, right?
Yes.
Hello? Okay. I need to. So I'm gonna just plug my phone because I cannot even print what Manju sent me with the Biden's. I will read it from my phone, but I need to plug it in because if it dies, that will be another problem.
Oh,
I'll
she.
be off for a minute here.
Hey, Yasin, how is
Okay,
your
where is-
internet connection? I
My
kicked
internet connection is okay, but my screen just show that Cora's internet connection is unstable.
because I kicked out twice from my
Yes,
connection.
it is. It's in the neighborhood. We were alerted that in my neighborhood, the internet. I'm gonna step out a minute to get my cord to plug in my phone.
Okay.
Hello, where's the video of everyone? Or video? Ako lang ba? Only one. There you go. Are we showing ourselves? What's the plan?
I don't know. Do we need to show ourselves? We are not exactly the panelists. Christina, definitely you need to come on the screen. So we have Manju as well. We have all the panelists. Just give me a second.
Okay. I probably be turning it off once I introduce Mark. He's not a doctor, right?
What did you
No.
say?
Oh, David, not Mark. David. Did I said Mark? David Lee Hawks is the one I'm introducing, right?
Yeah, give me a second, guys. I will be back. And I need to check my connection once again.
Okay.
Yeah, David Lee Hawks. Yeah. Did you send him a link, Shruti?
Manju, you're cutting off.
Well, I'm glad I'm not speaking today.
You can.
Remember, I'm not feeling good.
Well, you're still not
Manju,
feeling good. I'm sorry.
My internet service in the whole neighborhood is having issues. We were just alerted. So
no.
I think if something happens, we have to have contingency. If I freeze, someone needs to pick up quick. Okay?
Okay, Cora,
Maybe
I'll
Christina,
back
because
you up.
you're
Cora,
able.
I'll back
I
you up.
have no idea what were you supposed to do. What do you want me to do? Were you? You're the one of the panelists, right?
I have a copy of that. Cora, I have a copy
There's
of
only,
it,
there's only
so
one,
that's fine. It says you'll have
and you will take over.
meeting
Okay,
and join
you will
the
take
new-
over, but make sure because you're cutting up, Manju.
Yeah.
That's right. That's what I thought, because Suchi, can you give me the Zoom connection again? So I just don't want to have to go back and look for it, because if I am cut off, I will connect with my phone, but I need it right on my hand. Do you have
Yeah.
it?
So it's in the group text that she sent this afternoon. I will resend it.
Okay, Christina, read it to me, please.
It is
Read
Zoom
it to me,
ID,
please, Christina.
Zoom ID, hold on, 868 6383 3215
3215.
3215. Yes,
Okay.
I will
Okay,
screen
password.
password 90 83 and 12.
नहीं
Let me read that again. Zoom ID 868-6383-3215. Code 908312.
Yes, and I just texted it again.
Okay. If I'm kicked off, I will go in that way. Okay, I saw you.
I like your hair. You got your hair done.
Who will post the evaluation link at the end of the webinar?
Suchi.
Okay.
Presentation. So, Suchi, I think you already put David's bio already. I think I texted the question earlier. That should I just read it from that
हाँ?
slide?
हाँ, आपको मैंने होस्ट बनाया, कोस्ट बनाया था.
एक और से यहाँ पे लॉगिन कर लो ना.
Manju, I don't
Yes?
have Angela Dawson's. Manju,
Yes.
Manju, I
Yes.
don't have Angela Dawson's bio, but so I will just wing it. So
Yes.
what, do you remember what year she started at the Ohio Commission on Minority Health?
One second. Hold on.
1970 something, no. 2000 and something, after Cheryl Boyce.
Yes.
So I'm just going to say that she is a strong proponent for minority health and really has advocated for minority health through all these years as an executive director of OCMH. And
Uh-huh.
she is the voice
Uh-huh.
of our minorities in terms of health issue conversations.
Minority, you can say
discussions.
minority population in Ohio.
Yes, yes, yes. So she is the, I would say, a strong proponent, minority health, and a fearless and a strong advocate for minority health. She is the voice for minorities in all conversations. I'll wing it. I'll wing it. Is there anything that I need to add, Manju, other than, she's a leader and she's an advocate and she really
Yeah. She has helped build
turns act.
the minority. She brought up minority issues to the legislators in a very efficient manner.
Yes, the legislators, yes,
Yeah, exactly.
yes. Okay, okay, that should be, okay.
That
So,
should be
Suchi,
enough.
are you back? Yeah, Suchi, are you back?
Yes. I'm back. I
Okay.
just hope.
So I open and I say welcome on behalf of the coalition, and I would say on behalf of Manju, our executive director, on behalf of all our 8 member organizations throughout the state of Ohio, we welcome you to this first of the, and I go on, right? And then I say a little bit that this is, are you hearing an echo?
Yes, Manju, you are as an attendee also, and you
So
are.
I say a little bit about, I'm hearing
I'm getting out of it completely.
a feedback.
Your voice is breaking, Cora. Your voice is breaking a lot.
Okay, so
I think there's a lot of things to be grateful for today and a lot of hills yet to climb. Our country's vaccination targets are on target, but now getting nearly everybody vaccinated will probably pose a greater challenge and require increasingly targeted approaches. And anybody who's worked with Asian Americans or other vulnerable and hardly reached communities is in public health is very familiar with this. And we've got a lot of work to do in that regard. And we ought to be grateful for the greater emphasis on health equity that we're seeing from the current administration, from legislative bodies across the country over the past months, and from mainstream health organizations and companies, while understanding that the road is still long and there are many concrete investments that need to be made to groups and organizations that have been doing this work, this equity work, for years, even decades, long before equity was a buzzword. In short, we're grateful for the progress that has been made while recognizing that the work continues. It's tragic, but I think becoming a cliche, that the COVID-19 pandemic and all the destruction that it's wrought has provided us with something of a silver lining, a gift, and that is a very big magnifying glass that has people paying attention to equity, to disparities, to the fact that people of color in this country, not to mention globally, have worse health outcomes than white people, like never before. The attention is there. And whatever negativity has occurred in the last 4 years, thanks to trusted public servants, true public servants in many sectors, including public health, that damage has been mitigated, and now we're on a new path. So things do get better. And through the work that you all do, and the work we do together, we can accelerate that work. My remarks today, while informed by my roughly 12 years of experience in public health, which is a drop in the bucket compared to many of you, and include many lessons learned from mentors at NCAPIP, the Alliance of Multicultural Physicians, and the Anti-Diabetes Coalition. My comments today won't be affiliated with any of these organizations. These comments are my own. I am here as an advocate for Asian American health, for Native Hawaiian and Pacific Islander health, and also in solidarity with other communities of color and marginalized communities. I care a lot about words, and the terminology that we use beyond dictionary definitions. Feel that the terms that really matter, the terms that are bandied about, that are organized around, that are fought for and against, that inflame and inspire, take on their own meanings, and it's really about what we as large swaths of society come to a collective understanding on. Basically, what I mean is that the words that we use that seem to matter most nowadays in our work are defined by our perception of them. So how do we define what health equity is? Health equity has been called optimal health. It's been called optimal quality of outcomes. It's also been called negative things like social engineering, but despite any pejoratives, I think what we recognize is that health equity is positive. It is an antithesis to inequity. And one of the arguments for the definition of health equity that I enjoy the most is the justice argument. When we see the reality that there are whole subpopulations of Americans, categorized by race, ethnicity, including Asian Americans, with significantly pervasive and long-term poorer health outcomes than the majority white population, we've got an issue of equity, we've got an issue of justice. For a variety of choices, these exist. Not about individual choice, but based in inequity. And so I think that health equity is an acknowledgement that for all lives to matter, all lives need to matter more than they evidently have been by the health systems in this country for years. Now we know the needle is moving from lip service to investment, but ultimately we won't get there, so to speak, until the health disparities as we've known them are eliminated. And I think talking about terms, we've come to see that health equity is actually a positive term that's come to replace the elimination of health disparities. In other words, we've kind of moved on, and when we talk about the work, from our goal is to eliminate health disparities to our goal is to achieve equity. Now, the term health disparities really took off in 1985 with the publication of the Heckler Report out of Health and Human Services and the subsequent formation of the Office of Minority Health a year later. In that report, so many years ago, dropped the facts that Blacks and other minorities suffer higher rates of morbidity and mortality almost across the board of diseases and conditions. And OMH at the time became, and still is, the lead HHS organization in addressing minority health disparities, inequity, and to work with organizations and individuals like yourselves, like our partners across the country to find out why these disparities existed and how to address them. To find the facts, the data, and the understanding. What were the causes, genetic, environmental, behavioral, and to find the solutions. What could be done in the preventive health realm, in treatment, and to address the social determinants. We fast forward to 2010 and the passing of the Affordable Care Act, and there's been a number of advances as a result for equity, including the creation of more offices of minority health across HHS, which will hopefully get a shot in the arm in the current climate. And while we need the public and private sectors and mainstream health organizations and companies and everyone to be on board to achieve health equity, so much of the work has been done, is being done, and will be done for the most vulnerable communities by organizations like the Ohio Asian American Health Coalition. And I think many of you here have made health equity your life's work, the goal to which you continue to contribute. I thank you for that again. Every population needs advocates, and Asian Americans, by reason of our small overall percentage of the population, but other reasons too, have been rendered invisible or at best semi-visible until perhaps very recently. And I would argue that the primary impediment to health equity for Asian Americans is that lack of visibility that begins with a paucity of data. I know I'm speaking to many in the choir, but if you don't have the data, you don't have the information, and you can't identify the problem, and you certainly can't get to the solution. I want to talk a little bit about the model minority myth, or the stereotypes around Asian Americans and the significance of them. The social stereotypes of Asian Americans is really a coin with two sides. On one, the model minority myth. On the other, the perpetual foreigner stereotype. The model minority myth goes something like this. Asians are smart, humble, well-educated, education-oriented, hardworking, family-oriented, quiet, don't stir up trouble. And these characteristics and values align with good old American values that, if you listen closely to, you can almost hear the bootstraps being pulled up as they're spoken of. On the other side, the perpetual foreigner stereotype is one that, unfortunately, many of us have experienced firsthand. You're not really American. You talk funny. We are Siamese. And highlighted recently, during the pandemic, in much worse ways, outright hatred and violence, magnified even by racist rhetoric from other Americans who happen to hold powerful microphones. I speak of this two-sided coin to say that one, I think we should always be cautious and skeptical or outright reject judgments based on appearance, even if they're positive. So that coin can very easily be flipped. And the model minority myth has been wielded for years to the detriment of Black and brown communities who are cast as the bad minorities that should be more like the Asians. It's been detrimental to them and to Asian Americans in the equity space. I also bring it up to say that more and more in the halls of power, media, and amongst our brother and sister organizations in health equity work, is that our suffering and experience are being recognized and allies are coming forward. One of our partners in the Alliance of Multicultural Physicians, the NMA, which is one of the largest physician organizations, and was started actually when the largest physician organization, the AMA, refused to allow Black doctors to join. They formed their own organization over 100 years ago. And the NMA is huge. It's an American institution. If you've ever been to an NMA conference, it's easy to get lost. There's so many people, so much wisdom and influence and organizational power. And to work with them has been a great privilege. But when the stories were being reported in the media of all of the xenophobic acts against Asian Americans, in other words, #StopAsianHate, not only did the NMA release a proclamation along with other organizations, but they reached out to many of us individually to ask how they could help. And I think that's a sign of solidarity that we also need to pay forward or continue to pay forward. This is all good. This is evidence that we should continue to build bridges and relationships outside of our Asian American community. Now, the biases and stereotyping extends into health. This idea that Asian Americans are healthier. Probably the most significant initiative undertaken by the AANHPI Diabetes Coalition is the Screen at 23 campaign, whose goal is to address disparity and the issue of invisibility by increasing the screenings of diabetes among Asian Americans and to raise the awareness that low body mass index Asian Americans of all subpopulations are at risk for type 2 diabetes. And unofficially, we're fighting the stereotyped perception that a normal body type Asian, that's quote, you couldn't tell, wouldn't be at risk for a disease like diabetes. And the truth is that all Asian Americans, even lumped together, have an increased risk. You stratify that for Filipino Americans, for South Asian Americans, and other groups, and those risks are even higher. There are perceptions that need to be subverted. And Screen at 23 really highlights this dance we need to do as Asian Americans and AANHPI equity advocates. And there's an invisibility in the very designation Asian American that we can only address with disaggregated data. When we talk data, we often talk cold, hard facts. Disaggregated data will tell the true story. Disaggregated data is getting as granular as possible within that Asian American or AANHPI designation. It's something we've known we've needed for a long time, and that's a very proactive thing. It's something that we want. But let me put a spin on it and turn it into a negative, which might be a little controversial. We want disaggregated data, but aggregation is a problem. Aggregation is a problem. If our data is aggregated by the organizations that have massive resources, that do the studies, do the research, report out, that's unacceptable. If it's not reported, it's unforgivable. But whether it's the old argument that our populations are too small to be significant, to be reported, or if it's in the case of drug development, that to include us is an impediment to expediency, that's unacceptable. And there's people out there still who don't think that race and ethnicity matter like we know that they do. Well after the Affordable Care Act was passed, NCAPIP was invited to a coalition. It happened to be a coalition on vaccinations, run by a pretty mainstream PR firm in DC. And we met, and at the elevators after the meeting, one of the representatives of another organization, again, mainstream, I heard her say, why do we need to care about racial minorities? Why can't we just say minorities. I wish I'd said something then. I didn't. But it highlights that this is a problem. And since we're talking hard facts and not social stereotyping, race and ethnicity really matter. They impact health outcomes. The reason it's important in public health, the reason we need to stratify, disaggregate, we need to start somewhere. Because culture across racial ethnic populations is real. Difference in genetics and epigenetics are real across these categories. The research bears this out. I won't quote the studies because some of you are the experts, and we'll be hearing from you and others the statistics and the studies of why these things matter. I'm just here to tell you what I've learned in the past 10 or 12 years. I wish these categories didn't matter, but they do. That's just reality. And what they can teach us is integral to health equity, because health equity is for everybody, regardless of how you look, whatever your primary language that you speak, whatever the ethnic origin of your food or your socioeconomic status. But how you look shouldn't be an indicator for how long your lifespan is, including how likely a child is to die in infancy. I'll highlight another program, a big one. NIH has an initiative called All of Us that was started a couple of years ago, one that seeks to bring traditionally underrepresented groups in research, including vulnerable communities, including our communities, Asian American communities, into research. It's a great goal with a grand plan at the end, which is personalized medicine. The promise of personalized medicine is great, where every single person, no matter their age, sex, gender, sexual orientation, poverty level, disease history, their genes underneath their skin, but also their skin, their race and ethnicity, is able to get the most tailored, optimal care possible. To date, as of last week, All of Us has yet to include in their intake form Asian languages. So in between the ideal of a care that is customized to the individual, and on the other side, the one-size-fits-all strategy, which characterizes a lot of research and has for too long, what we have is one of the biggest factors that determines health outcomes, and that is race and ethnicity. We know it matters in medicine. We know it matters in health. We know it matters on many levels. Now, luckily, the current administration seems to have taken this under their advisement. And you could see it in their statements about our communities, that they're prioritizing disaggregated data. That's good. Because the aggregation of Asian American data masks our disparities. It gets in the way of the equity. It perpetuates stereotypes of health that aren't real for so many communities, helping render invisible Filipino Americans, Vietnamese Americans, Thai Americans, Bangladeshi Americans, Pakistani Americans, and so many more. These are groups that have their own characteristics. And we, advocates for health equity, we need to speak for them. Also lumped together with all of these heterogeneous Asian American groups are Native Hawaiians and Pacific Islanders. Lumped together for better or worse. We need to advocate for them too, always. They know even better than we do in many cases about the challenge of being seen as too small to be statistically significant. When they aren't in the room, we need to speak, and when they are, we need to let them lead while we listen. So, the opportunities for health equity in 2021. For 2020, we look back and say that's the year of COVID, or I guess we should say years, but the year that COVID started. It was also the year of a racial reckoning that has put health equity on the tip of everyone's tongue. And so I'd say that as we work to eliminate disparities, achieve health equity, a third term, arguably much more powerful, that we should consider using is that our work is also combating systemic racism. Health disparities, health equity, combating systemic racism in health. Now, Ignatius Bao, who has been one of the leading voices and most capable advocates for disaggregating data for many years, he's cataloged not only that at the start of the pandemic and well into the pandemic that Asian Americans, Native Hawaiians, and Pacific Islanders weren't being disaggregated, but also not even included. Asian Americans not even included in many states' data collection on infections, hospitalizations, and deaths. And that improved thanks to a lot of advocacy efforts by a lot of people. And that data has shown what we suspected to be true, which, again, increased hospitalizations, infections, and deaths. A huge problem with Filipino American nurses who are on the front lines. One of the other things that he cataloged was the number of state legislatures, and I believe Ohio is included in there, and also health organizations and provider associations that were declaring racism as a public health issue and a public health priority. So the majority is getting on board. Now, racism is an ugly word, but it's a powerful one that cannot be ignored as easily as disparities or equity. Framing our work as combating systemic racism in health is an acknowledgement that for this level of inequity to continue to exist in the cold, hard data means that certain lives aren't being prioritized. Folks might quibble about the usage of the word, but that perspective is going to be what defines systemic racism for public health and in healthcare systems, and moving from opinion to accepted fact. Now, you'll hear in the coming days about all the harrowing disparities, as well as the improvements and the outlook experienced by Asian Americans in chronic disease and conditions. I want to recognize an individual who pioneered the cancer disparities work in this space, and it's Dr. Moon Chen, a practically homegrown University of Ohio researcher who is the recipient of the first grant as the first Asian lead investigator for the first Asian-focused Cancer Research Disparities Initiative called ANCART. And I had the privilege to work with Moon on clinical trials disparities. You know, one of the issues that's an impediment to health equity for all communities of color, but certainly Asian Americans, is the lack of participation by Asian Americans in clinical trials. The clinical trials lead to the drugs and the therapies. So Moon's advice was so good in how to recruit for a clinical trial was to say, I would sign up and I would sign my mother up. So always thank him for that. We stand on the shoulders of giants who have done this work for years. As the saying goes, it's true. I happen to stand on the shoulders of one who was Moon's first partner at OMH, and I suspect that applies to many in Asian American public health work. And that's Betty Lee Hawks, who spent her career at OMH and who's been described by many AAPI equity advocates as our being Asian American, as our OMH. And it's Mother's Day weekend, so happy Mother's Day, Mom. OMH and other federal agencies have worked to provide grants and access to programs, but as is the case with Moon and my mother and so many others, it's the individuals in the driver's seat working together to make sure that those organizational priorities move forward. And of course, all of these programs and initiatives need to be funded and not just by government. So an opportunity in 2021 is money on the table. There's health equity money on the table more than ever before, probably. We might as well talk about it. There's grants, but there's also opportunities to subcontract. There's opportunities for smaller organizations that need funding and need support. Organizations that do things that larger organizations don't, can't, or won't do. There's conduits to corporations, maybe for the first time. And to the idea that a lot of these corporations or entities are jumping on the bandwagon, that they're bandying about the terms health equity in a performative way or to a performative degree. I don't care. Performance still makes noise. And if they're providing resources, it has impact, especially when they're joined with folks like you who have been doing the work, who have years of knowledge, and that intentional impact can be increased. I think for the next 2 years at least, if not for the next 4 years, and hopefully after that, we're going to see a continued upward trajectory towards health equity. And that includes across the board cardiovascular disease, obesity, hepatitis B, hypertension, diabetes, education, housing, other environmental factors, the way research is conducted with clinical trials, outreach to vulnerable communities, and to workforce pipeline issues. And we're talking about Asian Americans, but again, we Asian Americans, we ought to always speak out when we can on behalf of Native Hawaiians and Pacific Islanders, especially if your organization has a lot of letters in your name. Make sure you're advocating for every single one of those letters. I think that I learned this lesson even after a significant number of years in the space when the administration issued a proclamation for Heritage Month. And among it, they talked about data disaggregation, they talked about health equity, they talked about the AAPI experience and the work that needed to be done. And they also talked about the injustices that Asian Americans face, from the Chinese Exclusion Act to the internment of Japanese Americans during World War II to the murder of Vincent Chin, as well as the current climate of anti-Asian hate and violence, the xenophobia. I thought it was great. Someone shared it with me and I commented as such, linked to some recent work that we had done. And a colleague of mine, Dr. Martina Kamaka out of Hawaii, mentioned they left out no mention of injustices faced by Native Hawaiians and Pacific Islanders, including the nuclear testing in the Marshall Islands that has increased Marshallese cancer rates due to radiation. I didn't even see it myself. I was a little bit ashamed, and I told her so. So let's never forget to advocate for them. Building bridges and individual relationships are so important to our work. I think you heard in the beginning me include non-Asians in the work that we need to do. And besides being a good thing to do, it's key strategically for us to be seen. It doesn't mean giving up what we specialize in. It enhances our work. If we build relationships and get to know each other, we'll go farther. When you advocate for someone else, when you take on someone else's fight as an ally, as a friend, they're going to see you. Eventually, they're going to see you. When you break bread with them, spend time, share space, share your story, share and listen, get to know them. That becomes more than a bridge, that becomes a real relationship. And while many of us are professionals, and a big thank you to all the volunteers in this space as well, sometimes you are the most effective advocates for equity, this work is often personal. There's that shining city on a hill metaphor that's often used to describe the ideal America. There's also an American myth of the rugged individualist who sometimes extends their sphere to friends, family, church, community. When we continue to learn what people go through outside of our spheres, we learn a lot. It's on us to acknowledge whatever privilege we have and to lift others up. So let's not make it about just people like me any more than making it about ourselves as individuals. I want to acknowledge Cheryl Boyce, who passed away just last year, the first executive director of the Ohio Commission on Minority Health from its inception in 1986 to late 2010. Ms. Boyce was key to OMH's work in initiating and creating state OMHs, and she was a stalwart supporter of Asian American communities, going back to Moon Chen's seminal work. Ms. Boyce is a shining example of an equity champion who built many a bridge and relationship. My final point for 2021 to people working in health equity: let's get to the nitty-gritty more and make your voice heard. Not just to be heard, but bring ideas forward. Make your ideas heard. Even if your idea gets shut down, if it gets rejected, this equity work requires all of us at every career stage to offer things up beyond agreement or being for health equity. I'm not just talking about within organizations. This would be my recommendation to anyone. Always come with an idea, come with an action. If you want to collaborate, instead of saying, let's collaborate, propose an idea, propose an action, and see the response that you can get. I think it will do a lot of good. Talking about the Screen in 23 campaign, it would never have gotten off the ground if someone hadn't taken it upon themselves to fund a website and create some materials from scratch. Even though all the experts in the coalition were aligned in terms of the research, the policy, the advocacy, had worked hand in hand with the American Diabetes Association to change the screening guidelines for Asian Americans. And even though that guideline change was picked up by no less than 50 media outlets, big and small, and the leaders of the coalition said we needed to have our own PR campaign. It was someone raising their hand and volunteering to do it, and it growing from there to what it is, where we have no less than 7 states with Screen in 23 resolutions, including Ohio. And thanks again to Manju and Greg Lamb for your work. The Alliance of Multicultural Physicians includes the NMA, the NHMA, large minority physician organizations that have worked together for years, sat on each other's panels, attended each other's conferences. But it took a relatively low-level voice during a meeting of these groups to say, in addition to writing a letter on a specific subject, which happened to be minority participation in clinical trials, let's get together regularly. Now we meet every month with a different organization, chairing these meetings, and we've received our first funding for a joint project, the first ever between these groups. So propose the idea, raise your hand. It's a good starting point. There's so much going on and it's easy to get burned out, but if you've got an idea inside and you hold on to it, that's only going to make things worse. That's been my experience. If you've got something, it's got to come out. Otherwise, it'll make you jaded. It'll kill you. Innovation discussion requires that. And I think it's really important for everybody, from the lowest staff person to the executive director. So, health equity for Asian Americans, for AA and HPI, for communities of color, for all vulnerable minorities is work. If we speak up and cut through the chaff, we'll be able to work more efficiently and better inspire and motivate ourselves and each other. If we acknowledge that health equity is also about ending systemic racism, we might light a fire that gets us going even more. We must acknowledge the realities of our Native Hawaiian and Pacific Islander brothers and sisters, and we ought to build bridges and advocate for Black, Latinx, Native American, Alaskan Native communities as much as we can. We'll go from collective statements to multicultural coalitions, from gaining awareness or even recognition to inspiring leaders who embrace the AA and HPI designation and collective effort. We'll go from having health equity on the tip of everyone's tongue to reducing those health disparities closer to zero. We'll go from we've come a long way to now's the time. Keep up the work. Happy to take some questions. You can reach out to me at, put it in the chat box, dlhawks@gmail.com or David Lee Hawks on Twitter. Happy to work together too. Thanks for having me.
Thank you so much, David. Thank you. I wonder if you can You can hear me? My name is Cora Munoz. I'm the president of the Ohio Asian American Health Coalition, and I really, really appreciate what you shared with us, David. So insightful and hopeful as well, acknowledging that this work is hard. This is an uphill battle, but we're making progress. I'm so glad to hear about building bridges and collaborating not only with our Asian communities, but everyone else, because together we can make a difference. And of course, all of us here in Ohio know Dr. Moon Chen. We've worked with him for a long time and we miss him terribly, although we have invited him back in Ohio a few times. And of course, Ignatius Bao, we are aware of his work. And all of us also in our hearts still hold dearly Cheryl Boyce, as you mentioned, and Dr. Betty Lee Hawks and Dr. Moon Chen, Ignatius, and all those leaders actually are the people that we follow and whose shoulders we stand on. So thank you for acknowledging that. And especially mentioning that there's opportunity for funding, that's hopeful. And dispelling the model minority myth. Boy, there's so much. I have written and taken notes quietly here, but I will allow our audience to ask questions. And so we will take a few questions here for you, David. Chip Allen, who is from Ohio Department of Health, has a question early on, and let me just share that with you. And Chip Allen says, how should advocates address the unwillingness of governmental organizations to address hate crimes and stigma against the Asian community? You did address that, David, I know. I'm so glad to hear that. All efforts that are being done. Can you respond to Mr. Chip Allen?
Yeah, Chip, thanks for that question. So the question is, how can advocates speak to, I guess this is state legislatures mostly, or government who are unwilling to speak out against violence against Asians? Is that correct? Or people from Asian descent?
It's organization.
I'd say the only thing we can do is speak out. I think if we're already advocates, you know, and we have channels to these folks in government, whether they're going to do something about it or not, they have to listen. So, and if we don't have those channels, then we need to work with folks in this room, in other rooms, and be connected and make our voices heard. I think, you know, I shared the NMA's response to the Stop Asian Violence, to the xenophobic attacks. And that was, just to get that email really was highly motivating. I think to be seen is something that Asian Americans, Native Hawaiians, and Pacific Islanders we all kind of struggle with at some level. And so I think that in addition to making our voices heard and speaking out to those government officials, it's also the forming coalitions with other communities of color, with other minority groups that are representing vulnerable communities, amplifying that voice and advocating for each other will eventually reach a volume that these government officials can't ignore. I hope that answers your question best I can.
Thank you, David. Just to remind everyone, we had actually a statewide forum addressing increasing awareness of anti-Asian hate and violence. And we invited the governor, and he sent his representative to just speak on his behalf. Another question is from Angela Dawson, the Executive Director of the Ohio Commission on Minority Health. And her question is, what are your recommendations to individuals and organizations on steps to impact political will to dismantle systemic racism? can you share models that walk systems and organization to examine, address, and eliminate how racism is happening in their organizations? You did talk about systemic racism.
Big question, Ms. Dawson. I could probably learn a lot from you in this regard, but thank you for it. It's such a big issue. You know, it goes, if it's not a redefinition, you know, talking about eliminating disparities now has become achieving health equity. And if you want to take a more maybe necessary, unignorable, combative approach, it's about ending systemic racism. People can't ignore that. Nobody can ignore that word, you know. They will fight against it. They will say that it's not really racism, right? We saw this fight happen at the American Medical Association recently. They, their own podcast questioned whether there was racism among medical providers, let alone the system. And the AMA acted swiftly, apologized for those comments. It was a huge deal at that organization, the largest medical association, I think, in the world. So these conversations, these fights are happening at a level that we've never seen. And I think that when I say we, I guess I talk about the smaller organizations. Maybe we specialize in smaller subpopulations, work with a scalpel. It's really great to see those groups that have the resources and have the reach, not only reaching out to us and asking us to participate in ways that they haven't before, but investing and then also really carrying the torch themselves. So I think there's no simple answer, but I'm very heartened by stories like that from what the big guys, the mainstream guys are doing, and their reaching out to us is important. But as I said, you know, we really have to continue to band together and do the work, and hopefully, you know, we'll be energized by this, and hopefully we'll be better funded than we ever were before as well.
Thank you.
There's still the other comment that Director Dawson
Yes, so thank you.
yes, there's a comment that's related to dismantling racism.
Yes, and
Sheila?
I do think this is a unique history, time in history, and I do believe that it will be brief and that we will really have to act expeditiously. And the dismantling of racism and demanding a seat, if you will, at the table with healthcare organizations to invite ourselves, if you will, to the table with community organizations as well as individuals from the community to say, let's work together to dismantle healthcare disparities, which we know exist. And we know that they have the data and can disaggregate that. And then how do we develop those partnerships so that hospitals can begin to use their community dollars and invest in community-based organizations? And so I think it's a unique time. It's time for us to write to those boards, write to those healthcare systems and say, we would like to partner with you. We want to come to the table to help you resolve this long-standing practice of healthcare disparities so that we can then position ourselves for long-term partnerships and investments in the community. I appreciate your remarks. Thank you so much.
Go ahead, David. What I'd like to do, Ms. Dawson, I would like to just incorporate what your previous comment on community health workers. So I think this is kind of related as far as your comment about using community health workers and their effectiveness. And then you wanted to ask what are some of the successful models of how community health workers have been used in other states. Go ahead, David.
Oh, sorry. I wanted to make one comment to piggyback on what Ms. Dawson had said. regarding the systemic racism and equity. And you know, we have to get, this is, you said it perfectly. This is a moment when we need to take advantage. Like, I think we've been waiting for this time period to take advantage. And I'll just say that the one issue I talked a little bit about was clinical trial representation. And the big pharmaceuticals, Bio, who runs these clinical trials, intend to use healthy white males in their trials. And, you know, the excuse has been, well, the general population, or rather, what we need to do is we need to make these drugs and treatments as fast as possible. These are life-saving treatments, etc. And the cost benefit is not there to aggressively recruit. That has changed. The language has changed, but the outcomes haven't. So when they issue their proclamation or their 12 points for equity, because this is the time and now all the mainstream groups are talking about health equity, this is our time to really hold them accountable, our time to talk to Congress. Some of these things require legislation to really move the ball. So we should get together on an issue like that and a host of other issues and push for the kind of mandates that will require, because pharma has the resources. If they have to do something, they'll get it done. They'll lobby against it and all of these things, and they have far-reaching. But if they're talking about health equity, they got to listen to the experts in health equity who've been doing the work for years. Now they kind of have to listen to the little guys, and that goes, I think, for Congress as well. Corey, you had asked a question about community health workers.
It was Director Dawson's question as well.
Would you mind repeating it?
Go ahead, Angela, if you would like to read that.
One of the realities is that when we look at the use of community health workers, we see there's a very limited number of Asian American Pacific Islanders represented. And I think that through the use of community, and I do mean paid community health workers, so let me clarify that, paid community health workers. The Commission on Minority Health worked with the Board of Nursing to establish a certification process so that community health workers today, and in the vision of Ms. Shaw-Boyce, would be reimbursed for their work. And so that is actually happening today. And so we know that when we look at clinical trial participation, one of the ways that we could expand is to diversify the community health worker workforce and to use individuals who live in communities to impact the communities that they live in, so that when we talk about diabetes prevention, chronic disease prevention, or even chronic disease self-management, then we have a mechanism, we have trusted individuals from the community who are working in the community to be able to talk with individuals to increase participation. And so community health workers is one of the vehicles that we have used to impact chronic disease management, as well as have improved birth outcomes for infant mortality. So just wanted to know if you had any thoughts around that or any models that are working in other states.
I mean, you've taught me, my work has primarily been with physician organizations and been community-focused physician, that perspective. But what's been great, I think, since I began, there's been this movement. One, an acknowledgement that community health workers are critically important, that other providers besides physicians are increasingly important, have always been important in unique ways, but increasingly important in terms of being the primary care provider for so many folks. And the idea of health teams, whether those are different ways of organizing the provider workforce and including translators, including mental health experts, and working in conjunction together to better serve patients, has been something that is often is often talked about, and a lot of work I think has gone into that. The issue of increasing the representation, I think you mentioned, among Asian Americans, APIs, in the community health workforce. I think there's likely, and Cora and Manju might know better than me, maybe there's certain subpopulations that are better represented than others. I think that a lot of the work that I've been involved in is spreading the message among young doctors to go back into the community and practice, including getting into primary care or specialists going back into the community. It's statistically, even though so many Asian Americans are overrepresented in medicine, there's still a shortage of that. I think those numbers have gotten better in the last 10 years. And again, certain Asian American subpopulations are underrepresented in medicine. And so there's a lot that's going on, but certainly there's a critical need. And yeah, we'll talk more about maybe how to increase those numbers. But that's really great about the reimbursements.
And that is critically important, what Director Dawson pointed out. They have to be compensated. They have to be valued and appreciated. We do have community health workers that needs credentialing, that needs to be formally trained, and they're very willing. But if they are not compensated for their time, it does not motivate them if they have to get off from work and all the issues related to, a need to work and to give to the community, but we really need to pay them and value them. Yes, couldn't agree with you more. Thank you so much. I do not see any more questions in the chat. Okay. We will continue this program, but I just want to thank David for such a wonderful keynote address. And really, you touch so many points that all of us can talk about on, and their challenges. And they're really also, you've given us hope that the work needs to continue in partnership with others and in collaboration. Thank you so much. And please say hello to your mother. And I hope she's well. And of course, to all the mothers here in the audience, happy Mother's Day tomorrow. We will continue. We'll continue this program by just pointing out that this, in fact, this webinar series is a celebration of the National Asian Pacific Islander Month. We all know that, but I just want to maybe give you a little bit of a background of what it is and when it started, but also later on, I would like to read to you the proclamation that our president has given on Asian American and Native Hawaiian Pacific Islander Heritage Month. And I will read that to you in a minute because I think it's worth hearing from our top executive, our president. But just a little bit of a background. This National Asian Pacific Islander Month was first observed in 1979 under President Jimmy Carter. And it started as a API Heritage Week, and then it became expanded to a whole month in 1990 with President George Bush. Okay. May was chosen as the month for AAPI because on May 7, 1843, this was the date that the first Japanese immigrants arrived in the United States. And also in May 1869 was marked the completion of the Transcontinental Railroad, which could not have been possible without the contributions of Chinese Americans. So that's what a little bit of a history. But now I would like to read to you the proclamation of President Biden. I'll probably skip some sentences here. So he says in May, during Asian American and Native Hawaiian Pacific Islander Heritage Month, we recognize the history and achievements of AA and HPI across our nation in the midst of a difficult year of pain and fear. We reflect on the tradition of leadership, resilience, and courage shown by AAN HPI communities and commit to the struggle for AAHPI equity. We celebrate and honor the invaluable contributions of these communities to our nation's culture, the arts, law, science, technology, sports, public service, including the courageous ANHPI who served on the front lines of the COVID-19 pandemic as healthcare providers, first responders, teachers, and other essential workers. I want to interject that this is also the National Nurses Week and National Teachers Week. And there are a lot of Asians who are healthcare providers, physicians, nurses. Okay. The proclamation continues. During this year, Asian American and Native Hawaiian Pacific Islander Heritage Month, our nation celebrates the achievements of Vice President Harris, the first person of South Asian descent to hold the office of the Vice President. Vice President Harris has blazed a trail and set an example for young people across the country to aspire to follow, including members of AANHPI communities and women in particular. My administration, as President Biden, also recognizes the heightened fear felt by many Asian American communities in the wake of increasing rates of anti-Asian harassment and violence during the COVID-19 pandemic, and the increasingly observable layers of hate now directed toward women and elders of Asian descent in particular. Our nation continues to grieve the senseless killings of 6 women of Asian descent in Atlanta and the unconscionable acts of violence, victimizing our beloved Asian American seniors in cities across the country. Acts of anti-Asian bias are wrong and they are un-American and they must stop. My administration will continue to stand shoulder to shoulder with and HPI communities in condemning, denouncing, and preventing these acts of violence. We will continue to look for opportunities to heal together and fight against the racism, xenophobia that still exists in this country. Vice President Harris and I affirm that Asian Americans, Native Hawaiians, and Pacific Islanders make our nation stronger. I urge my fellow Americans to join us this month in celebrating AAN HPI history, people, and cultures. Now, therefore, I, Joseph R. Biden Jr., President of the United States of America, by virtue of authority vested in me by the Constitution, laws of the United States, do hereby May 2021 as Asian American Heritage Month. I call upon the people of Asian Americans, Native Hawaiians, and Pacific Islanders, and to observe this month with appropriate programs and activities. In witness thereof, I hereunto set my hands this 13th day of April in the year of the Lord 2021 and of the independence of the United States of America, the 245th. Signed, Joseph Biden Jr., President of the United States. Thank you so much, everyone. It is truly wonderful to hear our president support and certainly recognizes the achievements of Asian Americans, as well as the long history that we have in this nation. Okay. We have about 15 minutes to spare. I just want to take this opportunity to thank all of you, for participating and attending this webinar. As you know, this is a webinar series. So we would like to invite you to join us again tomorrow for a second webinar. And it will be on COVID-19 and vaccination. Very, very important topic. Also, to remind you that there is an evaluation form that we would like you to please complete. Okay. And there is a link to submit. Okay. And lastly, on behalf of Manju Sankarapa, who is our executive director, and all the 8 member organizations of the Ohio Asian American Health Coalition, I thank you so much for being with us, for supporting us, and for being our partners in all that we do for the good of our Asian communities and the larger society. A special thanks to our keynote speaker, David Lee Hawkes, and of course, Director Angela Dawson. And we always appreciate and are grateful for the support and funding from the Ohio Commission on Minority Health. Thank you very much. I was also reminded to let you know that if you will be able to participate and attend all or 4 of the 5 webinars, there will be special incentives for you. The last session will be on mental health first aid training. And to Miss Betty Hawkes, thank you so much to hear from you. Good
Thank
night,
you.
everyone. Take care.
Good night. Thank you.
Thank you. Thanks.